Okay, so I feel it's time now for the second presentation that is also extremely important because we never know what is aerosol generating procedure, what is not. We know bronchoscopy, we know ENT, but we don't know about endoscopy. So please, Shannon, proceed with the second presentation.
Okay, can you see the screen? Now I'm going to share a study that Philip and I has recently published in Gastroenterology. So the title is a proof of concept study. OGD is an aerosol generating procedure, and continuous oral suction during the procedure reduces the amount of aerosol generated. So, of course, we are here to discuss the COVID-19. And according to literature, in China, there were 23 healthcare workers who were infected. And another case report actually reported that around 40 out of 138 of hospitalized patients with COVID were healthcare workers who presumably had hospital-acquired infections. And according to the CDC, in February to April, about 3% of the patients infected with COVID were healthcare workers, but this was expected to be a serious underestimation due to underreporting and lack of structured data collections. So a lot of guidelines has been published, so including the ASDE guidelines, the AGA guidelines, the ESG guidelines, the AAP SDE guidelines, and of course the ISDE guidelines. So everybody has published a lot of guidelines on these papers, but in most guidelines, the authors assumed the insertion of the endoscope into the pharynx and esophagus was likely associated with similar risk of aerosolization of respiratory droplets as that of a bronchoscopy. The recommendations were therefore based on evidence generated from non-GI AGP procedures such as bronchoscopy. There is actually no scientific evidence to prove that EGD is an aerosol generating procedure, and that's why we proceeded to this study. So the aim of our study was to study whether OGD is an AGP and to look for ways to decrease the amount of aerosol generated. So this was a prospective observational trial to examine the aerosol generation of EGD in a quantitative approach. A post hoc analysis was performed to study ways of decreasing the amount of aerosol generated. So we included all patients who underwent OGD in our center during the month of May. And we included all patients, including elective or emergency surgeries, diagnostic or therapeutic indications. So we excluded patients who underwent EGD outside the designated procedure room because of a different airflow in a different room. And the different room size also affects the generation of airflow within the room. So we only measured it in 2 specific designated procedure rooms. And patients where the EGD had to be terminated due to patient's general condition or intolerance to the procedure. We also excluded pregnant patients. So what we did was that OGD was a normal OGD with air insufflation with a high flow setting in all patients. And they were all conducted in a designated procedure room measuring 37 meters square with a total supply of 6 air changes per hour, which is the standard international standard guidelines for an therapeutic endoscopy room with internal recirculation at 23 degrees and a humidity of less than or equal to 60 degrees. So all our staff wore surgical N95 face masks and enhanced personal protective equipment. So by the end of the study, we tried to use a dental sucker, as you can see here, to replace the suction during the OGD procedure with a suction pressure set at 30 kPa. So this dental sucker actually provides continuous suction in the oral cavity. So some of our patients are sedated, some are not. So our routine practice is not to sedate, and the conscious sedation is up to the endoscopist's discretion with either intravenous midazolam with or without intravenous pethidine. So this sedation in our center is provided by the endoscopist ourselves. So this is the particle counter. So this counter is actually a laser particle counter. So this channel actually sucks in the air, and then there is a laser inside, and it counts the number of particles of a specific size passing through a light emitter inside the counter. So there are 6 channels. So it was able to measure 0.3 micron, 0.5 micron, 0.715, and 10 microns. So theoretically speaking, anything less than or equal to 5 microns are considered an aerosol. So multi-level modeling was used to test a hypothesis. And this technique allows for investigation of within person, meaning the EGD procedure, during the procedure and before the procedure. So this was a level 1 analysis, and also between persons effect, which was a level 2. So between persons meaning does sedation have an effect or not, or does the dental sucker have an effect on the overall amount of aerosol generated. And this is the result. So this is the basic demographic data. So you can see that the mean age of patients we performed was around 60. Male or female is equal. Majority of the patients were unsedated. So only around 36% were sedated. And 30% of the patient had a dental sucker. And actually, 30% was done by specialists and 60% done by a trainee. The procedure time, mean procedure time is around 8 minutes. And a majority are diagnostic procedures with biopsy. So you can see the graph here. So each graph itself represents the size of each particle size and the count. So this is 0.3 DCF, meaning the differential count of a concentration of 0.3 micron. So 0.3 microns is equal to 300 nanometer, and the size of the coronavirus is around 190 to 210 nanometer. So our counter is only able to measure these 6 sizes. So you can see here we measure the particle count before we enter the scope. So you see that the baseline of the room, the particle counts are actually quite stable. So once we enter the scope, there is a sudden surge of the particle counts, and once we remove the scope, the count returns to baseline. So this is the same for all sizes, so including the 500 nanometer, 700, 1000, and 5 micron and 10 microns. So this 6 graphs on the right-hand side is with the addition of a dental sucker. So you can see that the surge is actually gone with the presence of the dental sucker, especially in the smallest size of the particle counts. So even in the 0.5, you can see there's a marked decrease in the spike. Of course, every procedure is different. And I just took one case out to illustrate that it is actually quite remarkable, the effect of the use of the dental sucker. So even in the 0.7 and size 1, it is slightly decreased. So this is the multi-level modeling. So if you focus on this line, so this is a within person analysis. So 3 stars, meaning the p-value is less than 0.01. So for particle sizes of 0.3 microns, during the procedure, it's statistically increased as compared to the baseline. Same for the 0.5, 0.7, and also for sizes of 1, 5, and 10. So you can see that the p-value is very, very significant. And if you look at here, the procedure times sedation, meaning the level 2 modeling. So we try to add sedation to see if sedation plays an effect in decreasing the aerosol generated. But you can see that these are all statistically non-significant in all sizes. But this may be due to a small sample size and actually due to confounding factors, because in our center, we only give sedation for anticipated difficult procedures. So therapeutic procedures or patients where you expect a more prolonged procedure, we give sedation. So this might be an intrinsic cause that the sedation factor turns out to be non-significant. But if you see here for dental sucker, after the addition of the dental sucker, it is statistically decreased the amount of aerosol generated in all sizes of particles. So this is what you can see. So this 0.3, this is a baseline particle count. This is during the OGD. And the blue line is without the dental sucker. The green line is with the dental sucker. So for sizes of 0.3, 0.5, 0.7, and 1, we saw a paradoxical drop of the amount of aerosol generated during the procedure as compared to without the dental sucker. It is normal that it increases during the procedure. For sizes 5 and 10, there is an increase, but to a lesser extent as compared to without the dental sucker. So this graph probably illustrates easier that the addition of the dental sucker as compared to the baseline with the dental sucker actually has a negative effect on the amount of aerosol generated in these 4 sizes. And as for the larger particles, there is also a significantly less amount of aerosol generated. So when I submitted to gastroenterology, they required us to submit one measurement for general anesthesia. So in our center, we only do general anesthesia for POEM or gastric or esophageal ESD. So I took the opportunity to measure one POEM procedure. So this procedure was done by Philip. So in the same way, the particle counter was placed at the mouth of the patient for the whole entire procedure. So you can see here, during the intubation, you actually don't see a spike. And during the extubation, you do not see anything at all. So this is because our anesthetists took a lot of precautions to sedate the patient very, very deeply before they intubate the patient. So once the scope is inserted, despite the patient is intubated, you still see a surge of the particle count. So the blue line is a 0.3 size, which is the smallest size that we can measure with that machine. And of course, you may say the patient is intubated, so this surge is probably the CO2 that we are inflating during the procedure because respiratory secretions should all have been blocked by the ET tube. And of course, this is also possible. So you can see here during tunnel creation, there is no spikes of particles. And interestingly, Philip's usual practice is after he creates a full tunnel, he will pull out the scope into the esophageal lumen to check how far he has gone. So he will pull the scope out back into the esophageal lumen and stomach and retroflex to check that his tunnel is long enough. So once he pulls out the scope from the submucosal tunnel into the lumen, you see that the smoke that has been trapped within the tunnel actually suddenly releases in one go. And once he enters the tunnel again for myotomy, there is a lot of spikes during the energy device that is used. And this is when he clipped the mucosa, and a second check of the stomach to make sure, and the stomach and the esophageal lumen to make sure there is no breach of the mucosa and scope out. So you can see that during a POEM procedure, apart from the scope insertion, the energy device and the smoke created is actually leaking all into out of the patient's mouth. And actually, there are scanty case reports that smoke actually can carry viruses, but of course, these case reports are not definitive. So the conclusion of this study is that this is probably the first study to prove that OGD is an aerosol generating procedure. And the second conclusion is the use of a dental sucker can decrease the amount of aerosol generated and probably decrease the risk to healthcare workers. And that OGD under general anesthesia may not have a protective effect on the amount of aerosol generated. And the POEM procedure, especially during myotomy, significantly increases the amount of aerosol generated. And the drawbacks of this study, of course, we are only measuring the particle count. So whether it would increase the infectivity of any respiratory virus is unknown. The measurement of the particle count was taken directly at the mouth of the patient. So we do not know whether these particles actually reach the level of the endoscopist or the nurse. And the negative effect of the sedation is probably due to a small sample size and presence of confounding factors. So actually, I've moved on to measure colonoscopy, and I'm now drafting the manuscript. So this is of our patient who had colonoscopy done, and these were measured with the same method, with a particle count placed at the anus around 10 to 20 centimeters from the anus. So you see that the small particles is actually not commonly seen. So the most commonly seen particles is actually the larger particles of 10. So 10 by definition is not an AGP, but for 5, 0.5, 0.71, and 5, these are all considered to be AGP procedures. So I've also, in my cohort, I've also patients who had the procedure done in CO2. And currently I'm measuring those with colonoscopy done with a water immersion technique, because when I analyzed some other data, I found that the amount of aerosol generated during scope insertion is much higher than that of scope withdrawal. So I'm now attempting to use a water immersion technique as scope insertion to see if we can decrease the amount of aerosol generated with this water immersion technique. So probably I hope to submit this manuscript within these 2 weeks. And of course, I went on to measure lab chole. So these are 2 of my trainees. So we put a long suction tubing. So this is actually measured so this is the chief surgeon. So she's my high trainee. And measuring at the chest level of the chief surgeon. So this is the assistant. And you can see we use the standard 4-port technique. So the port we use are the reusable metal ports, which are quite worn out. To my surprise, actually, I was just standing around and chit-chatting with the anesthesia. And I suddenly noted there was a surge of, so all along, there was no leak or anything. And the particle counts are actually at a very low level. But the baseline for the 0.3 particles in the OT was around 3,000. So once she took the hook diathermy out and started using it, we actually did not notice any leak ourselves when we were standing outside. But the particle counts was able to detect a leak that we were not able to see or smell at the level of the surgeon's chest. So where we placed the counter at her chin. So this persisted, and the spike has actually happened every time she steps on the hook diathermy. So we also put another one near the camera port. So there is also some subclinical leaks around the umbilical port that we used. So this probably is, I will probably go on to measure the particle counts with the use of smoke evacuator to see if that helps. And probably we would stop using the reusable metal ports and use the disposable ones to prevent leakage from worn out equipment. So the conclusion is EGD is an AGP, colonoscopy probably is, so I will try to publish the paper as soon as possible. And the use of the oral dental sucker may reduce the amount of aerosol generated. And now actually in the most of Hong Kong's hospital, we are using the oral dental sucker as during the procedure to try to see if we can decrease this these aerosol generated. And healthcare workers has to be well protected when performing GI endoscopy during this COVID pandemic. Thank you.
Thanks, Shannon. These are very important data, but of course we need to remind that this is a proof of concept. And for instance, we don't know if the magnitude of this increase in upper endoscopy and lower endoscopy is clinically relevant, but we must pay tribute because it is the first time that it has been shown. So now we have just 5 minutes to close the webinar, and I want to know from our panel what the reaction to this study is. So starting from Sergey, then Asim, and then Pramesh, are you fully convinced that upper-lower GI procedure are aerosol generating procedure? And do these data bring you to modify the way you are doing or thinking of endoscopy? Please, Sergey. Unmute yourself, Sergey.
Sorry, my video cannot start, so my voice is working.
Maybe we don't have time, so maybe we just go with a quick discussion, okay?
Thank you, Cesare. Briefly, I would like to say that that such kind of guidelines are very important for all the countries, and and one of the most important point, sometimes we forget about the high risk to be infected in the staff rooms or in the coffee rooms. I think that this is the most important point for me as the head of the department, because as I have seen in my hospital, most of the doctors and nurses have the highest risk to be infected, not in the endoscopy rooms.
Asim.
Thank you.
Thanks.
So I think thank you very much for that really interesting presentation. I thoroughly enjoyed it. My point is, it's not only about today. It's not about COVID. It's about continuous exposure of the endoscopists, the surgeons who are in these environments over their lifetime. So being a surgeon, if I continue to inhale the smoke, which may or may not contain virus, but may expose me to develop a lot of allergies, health conditions, which are occupational health conditions over a long time. So certainly adds to the volume of literature and indicates that we need, as surgeons, as a society, as a physician, we need to protect ourselves. This is not only relevant to this, it will be relevant tomorrow and days to come for everybody. So thank you very much for that.
Very good point. Pramesh.
Thank you, Cesare, and thank you, Shannon. That was a fascinating presentation. I wouldn't have for a moment expected lower GI procedures to be aerosol generating. So I think we need to be a little careful about what we define as a COVID risk and what we define as a generic risk. We know that COVID is mucosal, COVID is predominantly respiratory, COVID is predominantly upper respiratory and sometimes lower respiratory. So though even laparoscopy, I mean, there are case reports of how there have been viral particles seen in smoke evacuated, viral particles seen in ascitic fluid, in peritoneal fluid. We need to be a little careful about how far we take this. And I would be very circumspect of any data that comes out which doesn't tie in with what we already know, that it is a predominantly respiratory virus. So what I mean by this is that when we start deciding on interventions to avoid exposure to the virus, we also need to be cognizant of the fact that though technically many procedures might be aerosol generating, we need to also figure out what are COVID-19 aerosol generating. So I completely take Asim's point that smoke by itself is allergic and it might be of harm for surgeons and endoscopists, but at least from a COVID point of view, I would want more data before I conclude that even lower GI procedures are potentially harmful.
Very good point. Shannon, do you want to reply to the last point by Asim Pramesh?
I actually totally agree with Professor Pramesh. That's why I was having a bit of difficulty in writing the manuscript, because as I've said, the drawback of the study, we only measure the count itself. So we were never able to prove infectivity. So none of our healthcare workers were infected during any of these GI procedures. But I guess in this era of COVID, it's probably safer to err on the safe side than to be sorry later after getting infected. So our GI colleagues are trying to gather more data on the stool samples and the aerosol in the room for active COVID patients. And probably this will give us more information on whether it's really effective.
Okay, thanks. On behalf of ISDE, let me thank, and also on behalf of Philip Q, my co-chair, who couldn't be with us because of emergency surgery. Let me thank our outstanding panel for the incredible contribution. Personally, I learned a lot of things today, and this is why we are here. So thanks all the audience for being with us, and let's catch up soon with our news on COVID-19 and apparently eye diseases. Thanks, and bye-bye.